Our next session is New Ways of Working, how to boost elective recovery with simple, innovative and effective digital patient communication. Please welcome to the stage our speakers and session moderator, health editor at The Times, Kat Lay.
Hello everyone, and thank you very much for coming on day 2 of this conference. We're actually going to start with Jacob, who is going to talk us through his thinking on this topic, and then we're going to come back and Matthew and Jacob are going to have a brief discussion, and then we'll go out to the audience for questions. So take it away.
Thank you very much, Kat, and thank you all for joining. And so I'm going to start by taking about 10 minutes to look at this elective recovery challenge and what are the new ways of working that we need. Now, people are probably very familiar with this graph or a version of it, the number of patients on a waiting list. I want to focus on this bit over here, and particularly the slope of it. Why? Because it's growing by about 100,000 patients a month. And what that means is this isn't just about clearing the backlog. This is about making sure that we've got ongoing capacity that at least matches the ongoing demand. Why? Because if we cleared the backlog a year ago, there'd still be north of 1 million patients waiting for treatment. And so then the question is, how can we get through radically more demand without an increase in capacity? And we've got to recognize what got us here won't get us there. We can't just keep doing more of the same and throw more people at it. So I'm going to quickly talk through the 3 levers we've seen had the most impact. And I'll explain each one, but we've got to reduce demand, we've got to increase productivity, and we've got to proactively prioritize those patients waiting. So let's start with reducing demand. And what this boils down to is giving patients care when they actually need it. Now, to illustrate this, I want to imagine your GP practice, and imagine they send you a letter every 2 months, and they say, come in for an appointment, Thursday in 2 weeks' time at 11:20, and if you need anything sooner, then you can try calling us, but you're probably better off going to A&E. And if you don't need anything, well, come along anyway. Like, don't DNA, come along. Overnight, that practice would collapse and be overwhelmed. But that's exactly how we run outpatients today. It's all based on a schedule rather than when patients actually need care. And so we've got to shift that model. Now, you're probably sitting there thinking, we've heard this before, that's PIFU, maybe we're doing this already in our trust. But what we've seen is to actually get the benefits out, there's 3 things that have to be true. You've got to triage patients. You can't just be that when a patient gets in touch, they get an appointment. And why is this? Well, what we see time and time again is somewhere between a third and half of those contacts don't actually need an appointment. Things can be resolved remotely. Might be some tests need to be ordered, might be a medication change, but an appointment's not actually needed. But then also this has to be done for 100% of patients. Why? Well, if you only do it for 3% or 5% or 20% of patients, like some of the targets have been, the maximum you can get is 3% or 5% or 20% of the benefit. But the more important reason is it's actually really inefficient running 2 different pathways, running the old model of we'll tell you to come in every 3 months, whether you need it or not, and PIFU at the same time. You've got to protect capacity in the appointment book for those PIFU patients. Your clinicians have to make decisions around which pathway do I put a patient on. Patients start to get confused when they move between the 2. So you've got to move all the patients over. Now, obviously, the pushback is, well, what about those patients that we don't hear from, but actually they might be quite unwell? We need to check in with them. And the good news is that can be automated. We can check in with patients and say, we haven't heard from you, but we just want to check how these symptoms are doing. And then the third thing we've seen has to be true is that contact has to be asynchronous by default. And what do I mean by asynchronous? I mean, it's not a phone call, it's not an appointment, it's a patient going to a website or going through the NHS app or sending an email and getting in touch. And why is this important? Well, one, it's actually pretty tough to staff phone lines reliably. But 2, it makes it a lot easier to get that to the right person. It might be getting that in front of their usual consultant. It might be, right, this can be given to the juniors or to the CNSs, or actually the pharmacist needs to look at it, or we need a few people to discuss this. So much easier when things come in asynchronously. Some examples. So one from general practice, somewhere between 5 and 10% of GP practices now, they've got rid of the 8 a.m. phone rush. Patients, whether they come through online, call up, through the NHS app, in person, get put into one queue. The practice go through, triage each one, and decide what's most appropriate. What's more exciting is you go into these practices and they're calm and staff are like buoyant, and you see patient requests come in, and within 10 minutes they're getting a response. If they need something face-to-face, it's usually the same day because they've implemented this exact model. And we see the same in acute. So in services where they're using clinical nurse specialists, often they'll be giving out an email address or a way of contacting them to a patient, and those nurses will be triaging, okay, what's actually needed here? And quite often it's not an appointment. The second area we've seen have the most impact is increasing productivity, and is specifically doing this by moving activity from what would have been appointments to happening through messaging. Why is this so important? Well, if you look at health systems, not just in the NHS, but globally, our unit of value creation, our unit of delivering healthcare is the appointment. And what that means is 75 years ago, when the NHS was founded, a 15-minute appointment with a doctor took 15 minutes of a doctor's time. Today, 15-minute appointment with a doctor takes 15 minutes of a doctor's time. And so we've had no productivity gains, stagnant productivity growth. Now, what happens is when other sectors in the economy, manufacturing, retail, finance, have huge productivity gains, that massively pushes up inflation in healthcare above other sectors. And that's why in health systems around the world, healthcare spend as a proportion of GDP keeps going up. It's why we end up in situations like this where we've got industrial action from the front line because we haven't been able to keep pace with inflation because we haven't seen those productivity gains. And economists call this Baumol's cost disease. But what it means is for as long as healthcare is only delivered in appointments, costs are just going to keep going up, and we won't have enough staff. Now, the benefits of starting to do things through messaging are you can take a couple of minutes instead of taking 15 minutes to deal with something quick and simple. You have a lot more flexibility. You can say to a patient, let's actually monitor this for a couple of weeks. If you need something, just message us back. But let's use time as medicine, and let's monitor this. And things can start to be automated. And I'm not talking here about AI algorithms making clinical decisions. I'm talking about taking a good history, asking the relevant questions for that presentation. And so again, a couple of examples. 3.5 years ago, if you had a rash on your arm and you contacted your GP, they'd tell you when the next appointment is, and you'd book it, you'd come in and you'd show them, and you'd come up with a plan. Today, in most GP practices, if you contact them with that same rash, they will ask you to send in a photo, if you haven't already. They'll review that. Maybe they'll ask you a bit about how long it's been going on, any other symptoms. And then if you need, say, a topical steroid cream, they'll send that off to the pharmacy without ever having an appointment. And so what would have been 15 minutes of clinician's time gets done in about 2. And that's where some of these productivity gains come from. And then if we take an example from the acutes, and this is a great example we've seen the team at UHL in Leicester do, in thoracics, patients who've had lung cancer are coming in every 3 months to be screened again. And 95+% of the time, that scan is normal. And what was happening is patients were being told, we'll book in an appointment to give you the results in a couple of weeks' time. Now, first of all, that's not that pleasant an experience, waiting to hear if your lung cancer's come back for a couple of weeks, when 19 times out of 20 it hasn't. But secondly, what was 3 days of clinic time and appointments telling patients their results are normal can now be done in a couple of hours. And so again, that's where these productivity gains are coming from. And patients love it too. Patients don't want to wait around for the morning to wait for a phone call from a withheld number, and if they miss it, then they're trying to work out who it's from and get back in touch with the right person. Huge sectors of the workforce can't do that because they're teachers, because they're working on checkouts, or they work in prisons, or they're in meetings. They can't just take a phone call any time of the day. So they love engaging like this. And so the question I've got for all of you is, what proportion of your activity doesn't actually need to be seen if messaging was an option, if it wasn't just we have an appointment or we have letters? The third lever we've seen is one of proactively prioritizing patients. And what this boils down to is there will always be more potential demand in the system than there is capacity, and we've got to prioritize what we've got. Historically, though, this has been really hard to do. It's involved either getting patients in to screen them, ask them questions, or at best it's been calling them up. The good news is now this can be done remotely. We can at scale contact patients. And so, again, a couple of examples. 3 or 4 years ago, if you went into a GP practice and they had a cohort of patients with asthma, they'd be booking all of them in for an appointment once a year and asking them a set of questions about how well controlled their asthma is and then coming up with a plan. Now, if you go to most GP practices, they will contact all of their patients with asthma, they'll ask them a standard set of questions, and then they'll segment the patients by their response. So they'll have a group that are actually really well managed, and I'll send them back a message and say, you're managing your asthma well, keep doing what you're doing. If you need anything, we're here. Then there'll be some in the middle. Maybe they need to send them a video on their inhaler technique, or they need to give the option of a call with a respiratory nurse. And then there'll be some, actually, we really need to get you in. We need to review your medication, and we need to come up with a new plan. And that's how asthma is now managed in most of general practice. And again, to take an example from the acutes, this one's also from UHL in Leicester. Month on month, their waiting list is going up. This is probably quite familiar to people in other trusts. And then they started contacting patients and saying, do you still need to be seen? And very quickly, month on month, the waiting list started going down. About half of those patients, about 18,000 so far removed, about half of them saying, I don't need to be seen, and about half of them saying, I don't need to be seen now, but I still want to have a way of accessing care. So great, we can put them straight into PIFU. And for operational reasons, actually, we had to pause this validation, and very quickly we started to see that list going up again. So in summary, the only way we're going to address this big elective recovery challenge is if we start to change the model that we're delivering care. And we've got to reduce demand by moving things to being led by patient demand. We've got to increase that productivity by not just delivering everything in appointments. And we've got to go and proactively prioritize the patients that are waiting and the demand that there is and do that at scale, because we're not going to get there by just doing more of the same. And the really hard bit of this is not the tech, and I say that as someone who comes from that space, the software side of things. It's the implementation. It's actually changing the operating model, not just bolting this on top of what you were doing before, but actually completely changing the delivery model of these services. So if you're hearing this and thinking, oh, actually, we want to be bold, we want to change how outpatients work, we want to work more like this, then please do come on over and talk to us. Thank you very much for listening, and yeah, very excited to now discuss this with Matthew and Kat.
Thank you. Really interesting. Can you tell us about your background, just briefly? How have you come to be involved in waiting lists and GP communications?
So as an organisation, we actually started on antimicrobial resistance and antibiotic prescribing. Did that for about 18 months. Found it very hard to get that forward because there were all these other challenges in the system. And so we went and spent about 6 months kind of living in a GP practice, doing all these transformation projects. And what we saw time and time again were communication barriers. You'd have a patient come in who's been seen in outpatients, they need to start a new medication, they go and see their GP, but there's no clinic letter, and so they're left sort of trying to guess what to do next. Or you'd have a paramedic calling reception who's with a patient trying to find out their care plan. And so we realized that actually the root cause of so many challenges in the system was communication, and specifically it being very difficult to communicate. We then spent the next few years trying to address that in general practice. So about 98% of GP practices use us now to communicate with their patients. And then more recently, we've been trying to take that to not just acute trust, but also community trust, mental health trust, other part of the system. And exactly as spoke through there, a lot of the same, the same learnings, the same opportunities. So we've been taking that into, more and more acute services.
So, Matthew, why does the system struggle to do communication well?
Yeah, so it's a fascinating presentation by Jacob, and let me start by saying if we all did what you've described, the world would be at a better place for patients and for us. So the question for me is, why is it, exactly as you say, Kat, why is it so difficult? And I think that there are a couple of reasons, and then I want to talk about the kind of theory of change, because I think for me that's the kind of critical element here. So why might there be resistance to doing this? Well, one reason is completely obvious, and we're all aware of it, which is that, you know, when you come along, Jacob, and you say to managers, clinicians, that this is the way to do it, you're not coming along to a situation which is stable, adequately funded, no other demands. You're coming into a kind of maelstrom of a system where demand is continuously growing, capacity is limited, there are staffing shortages, etc., 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 and we're being asked to do a lot of other things at once. So you're coming into, it's not a kind of greenfield, so you're coming into that kind of context, and that's the kind of obvious thing. But I think there's a second thing as well. And I say this at the risk of, and you know, you must argue with me, Jacob, if you think I'm being too kind of, I don't know, not getting on the project really. But I think of my mother-in-law. She's a absolutely core high-end NHS user, right? And I think of her experience of trying to engage with systems that have been subject to an intense technological productivity focus. I think of her engagement with her broadband supplier. I think of her engagement with the local authority. This is somebody who is not confident about digital. Yeah. And it's an absolute nightmare. I mean, it's a desperate experience for her, trying to find somebody who can talk to her, trying to negotiate a system which makes assumptions about people's capacities. You know, I was in Rusholme earlier this week. Brilliant practice, absolutely doing active triage in the way that you said, but I think 4 out of 10 of their patients don't have a good command of English, for example. So in your slide, you said patients love it. And I think in a lot of clinicians or managers say, well, there's no such thing as patients. Yep. They're very, very different people at very different stages. And actually, generally, the people we're most concerned about are the people who this might be most challenging to. Now, that does not mean we shouldn't do it. It absolutely doesn't. But what it means is we need to be conscious of the concerns that people have about new systems being systems which are genuinely inclusive and genuinely work for everybody and don't turn into, you know, the way broadband companies treat their customers, right? So what does that mean for theory of change? So I did a lot of work on, probably my specialist subject really is change and why it's so difficult to do, particularly change involving human beings. And what I found when I looked into this, why is it that most policy fails? Why is it that 65% of corporate change strategies fail to achieve their objectives? And when we did this work, we found 2 reasons. So the first reason is that what happens is you introduce an intervention into a complex system, and you focus on this intervention, but there's all sorts of other noise. And so what happens is that the intervention bounces up against all the other noise in the system, and it starts not to achieve what it's supposed to achieve, or sometimes even achieves a negative consequence because of unexpected, unforeseen consequences. And we see that all over the place. The other problem is a kind of form of path dependency, which is, you know, it takes a long time to get permission to do something. You know, so you come into a system or a trust and you say, look, do this, and it takes months and months and months, and no, we're going to do it, we're going to put the investment, we're going to do it. And then you set off, and then almost immediately things don't quite work in the way that we thought they were going to work for any of a lot of reasons. And then there's a tendency to kind of double down, to kind of plow on and say, no, I've got a mandate to do this, we've got a contract to do this, we're going to do this. Again, try to silence out the noise of the fact that actually things aren't quite working. So what do you do about that? So I think these are 2 things that we need to do. One is we always need to recognize that innovation involves the interaction of technological systems and human systems. And that complex interaction of the technological and the human system is, I would say, ultimately inherently unpredictable. There is an unpredictability about how human systems and technological systems interact with each other in terms of what they lead to. And so what does that mean in terms of how I think we need to work? So the phrase we came up with when I did this work at the RSA was, I said the way to think about change, or we said the way to think about change is to think like a system and act like an entrepreneur. What do I mean by that? What I mean is agree where it is ultimately we want to get to. So what is our vision of what this would look like? And is everybody bought into that ultimate place that we want to get to? How would this feel as a whole? What would be the experience for patients, for clinicians in this system? And are we clear about what we want? And that's what it is. And that's a whole system perspective. So how does this relate to other changes we're trying? What would this feel like? But then the entrepreneurial bit is you've then got to adopt a highly agile approach to implementation in which you can adapt as things don't quite work in the way you want to, as you come up against bits of human resistance, as events kind of happen. And what I think that means, I'm just really interested, Jacob, in your kind of response to this, is I think it means that the challenge for our commercial partners is to have the quality of relationship that enables us to be, firstly, really do the work of making sure we agree about where we're ultimately trying to get to here, take that time to get that shared vision, and then secondly, to have the kind of relationship that enables us to work and adapt together in real time. As too often, the experience that the NHS has is tying themselves into relationships that become very inflexible when things don't quite work out as they were supposed to work out. And there's probably a lot of people in this room who could tell you about contracts that they're involved in, which, well, they're plowing on with them, but they're not, you know, if they could go back, they would do them differently, but they're kind of stuck slightly. So that's my kind of question to you, is I look at this and I think, wow, and I guess if I was Steve Barclay, I just look at it and I go, right, everyone, you're just going to bloody do it by next Tuesday, and if you don't, you're useless kind of thing. But the world is more complex than that, and I'm interested in your perspective as an entrepreneur, as a business leader, on how do you get that relationship right in order to have that kind of agility and responsiveness?
Yeah, so I want to agree with parts of those and also to challenge a few things there. So in terms of that collaborative, joint enterprise delivery, absolutely essential. And why it's so important is because we're actually not the innovators. The innovators are frontline staff, and the only way that they're going to realize that is if we work. Those examples I spoke through there are frontline staff coming up with, hang on a sec, these patients, there's a much better way, but they haven't had the ways of working to be able to go after that. And to your point around unforeseen and unpredictable challenges, one of the biggest failure modes we see is organizations we have implemented PIFIT, we have implemented online consultations. It doesn't work. It's just overwhelmed us. Why? Because they haven't done the people part, because they've it's been bolted on top of their old operating model. So they've got the 8 a.m. phone rush, but now they've also got an online channel. So the staff are like, well, we're just even more overwhelmed. Or they've put in PIFU, but it's only for a few patients, and staff are a bit confused as to when to use it, and so you don't get the benefits out. So it has to be that co-creation. The hard bit is then when you've seen, because like in everything, there's a distribution, you've got variation across the system. When you've seen things work really well in one place, that balance of transplanting that, but also taking people on the journey, adapting it to local circumstances. The bit I wanted to challenge a bit is the piece around inclusion technology, because it's absolutely critical, right? We have to make sure that the whole system can access care. But we found three things. So one is that there are a lot of misconceptions about who can and can't use technology. And if I look at, so we booked about a third of the COVID vaccines. When we were in phase 1, phase 2 of the program, over 75-year-olds, 90% of them were booking online. Now, often it was a family member helping them, but these conceptions that older people can't use technology, or also if I think about patients who, for example, don't read English, getting a message is great because they go and show it to a family member, and, when they're able to, and get that translated. They copy and paste it into Google Translate. So there's those misconceptions. Then there's also, we've got to recognize that the system at the moment that we have, sending letters, telling people to come in at a certain point in the middle of the day or to wait around for a phone call within a few-hour window, that's not accessible for loads of people. Lots of people are not at a fixed address, or they're homeless, or they're traveling for work. They can't get letters. They're in jobs where they can't just take a phone call any time of the day. And so we've got to recognize that the current system actually excludes a load of people already. So those are some of the things we've seen in inclusion. Now, the exciting opportunity is in those practices where they're shifting to a total triage model. 85% of the demand will come through those digital channels. But what does that mean? It means their reception team now, the phones aren't ringing off the hook. There's if there's any wait on the phone queue, it's 2 minutes instead of 45 minutes. And so the patients who can't go through digital channels can call up, can speak to someone. And so making access slicker and better for one group of patients actually ends up helping all patients, because same example with if you free up staff time with those simpler patients, say in the asthma example, free up staff time for those patients, suddenly the respiratory team has more time that they can spend on the really complex ones. So it is quite nuanced, I'd say, the inclusion piece. It's not just tech will only help the people who can use tech, which are only young people, which I know is not what you're saying, but it's a lot of what we sort of come up against.
So do you mind if I...
No, please, carry on.
So I really agree with that. And I think, look, I'm not on your marketing team, but I'm available for offers. But I think there's something about how you talk about this. So when you say this enables us to do other things better for our patients, I think that resonates with this kind of idea of where we're ultimately trying to get to, in a way that sometimes when we talk about productivity and efficiency, it doesn't feel like it's doing that. So I think the tragedy of, not the tragedy, but the problem of 15-minute appointments is that some people need 2-minute appointments and some people need 30-minute appointments, right? And so the danger is when we kind of say, well, look, isn't it a good thing if people don't come and sit down with the GP, but they instead transact digitally? GPs will say, well, hold on, the phenomenon of people as they leave my office saying, oh, there's just one more thing. Yeah. That phenomenon. Yeah. Or the fact that it is well known that if you spend twice as long with somebody in an initial consultation as a GP, they will use GP services less in future because you will have had a really good quality conversation. And so the more we can articulate these things in terms of the human objectives we've got, as well as the fact that we can be more efficient and productive, the more powerful I think it is in terms of buying people in.
Yeah, definitely. And like all of this, right, it all comes down to the nuances. So if it becomes appointments good, appointments bad, messaging good, or vice versa, we've all lost. And time again, we see actually patients and clinicians together are very, very good at working out what is most appropriate, for that given need. And it's not as simple as, some patients like appointments, some patients like messaging. In general, some patients like appointments when they really need to discuss a complex thing, and when they just need to, update a prescription or, check in about this medication or what their test result was, they like messaging. And so we've got to move away from the one-size-fits-all, but the good thing is patients and clinicians are very good at recognizing what they need to use if they've got that suite available.
Yeah. I wanted to ask you both about what we're hearing from politicians in terms of technology in the NHS. I mean, it seems very much to be seen as the solution. That's what's going to help us get out of the mess that we're in. Are people like Wes Streeting, Steve Barclay, expecting too much, putting too much emphasis on technology, or is it really going to help?
No, look, it's going to be absolutely transformative. And also the other point, which is the point I made on this stage yesterday, is that if the NHS doesn't do this, then these opportunities will be provided outside the NHS to those people who have the confidence and the capacity to access them, and we'll end up with a greater polarization between the kind of the healthy haves who use the full array of biotech and digital, and the unhealthy have-nots who are relying on an NHS system which doesn't provide the offer of kind of convenience and personalisation. So no, absolutely. I think the challenge for politicians is to recognise two things. Firstly, that even if a solution is really compelling like this, it still needs to be adapted to local circumstances. It still needs to build itself around, look at ICSs, how you have a solution like this in inner city Manchester and have you a solution like this in, I don't know, Somerset or Gloucestershire, in a rural community. There are nuances to how you do this. And so we have to provide space for people to do that. And secondly, let's just have a small number of key priorities. Richard Meddings said, I think on this stage yesterday, that he'd worked out that there are currently 256 technological priorities.
Staggering numbers.
256 technological priorities directly mandated by ministers. Well, that's probably about 245 to 250 too many. So, yes, absolutely technology, but recognise the importance, as we've been saying, of technology working with people in context rather than being over-defined by the centre. Of course, there are platforms which need to be designed by the centre, absolutely, and systems and fidelity elements that have to be done centrally. And also, just give us a manageable number of national priorities, partly so that we can also have some local priorities.
So I know Wes Streeting yesterday was talking about bulk buying in technology, so you don't end up with this postcode lottery where some hospitals are using fantastic new schemes to diagnose skin cancer and so on, and others simply aren't. What's been your experience of dealing with the system? Is it frustrating to have to go trust by trust?
I'd say every route has its challenges, both as technology organisation, but also for the system. So things done centrally, yes, you can get great scale, you can sort of avoid having that postcode lottery. It also then crowds out a lot of innovation because it's harder to bring in solutions in more local settings. If I think about, when we started this organisation, we were going around to individual GP practices who were just getting set up and messaging their patients in a way that they couldn't do if there was, everything had to come through a central route. And then also as a technology organisation, we have some, central contracts and arrangements. It's not just they're difficult to get, is actually it comes with a lot of uncertainty. It actually, then implementing it, you still have to work locally, and so there isn't a perfect route. But I very much agree with this. Like technology, I say this is a technology organisation, is not the solution. It's an enabler. We talk about integrated care, frontline staff in different organisations working as one team. Like that's what it boils down to for us. But you can't do that if you can't communicate. So is just giving people technology going to solve anything? No. But is it going to enable them to work in a more integrated way? Is it going to enable them to change how they're doing outpatients so it's much more modern and fit for purpose? Is it going to enable them to screen their populations and be much more proactive? Like, absolutely. But you've got to do that joint work.
But I think a really important point here is that where I see really good relationships between the health service and commercial partners, it's because of the quality of those local relationships, very often between lead clinicians and partners. And actually at the national level, it's much more brittle. It's big decisions, and then there's all the kind of issues of public accountability and propriety. It's quite slow, it's quite cumbersome. Every once in a while, there's an absolute disaster because everything is chucked into something, and when that happens, it can set us back for years, and there's been 3 or 4 examples of that. So this model of agility, I think, is really important, because if I'm right that a critical element in innovation is having a relationship with commercial partners where we can adapt and not over-define things but work together to a common outcome, then that needs to happen quite a lot locally.
Okay, I'd like to open it up to questions from the audience. So at the top of the stairs back there.
Hi there, I'm David Atherton. I'm a GP and Eutoxeter Clinical Director of the Staffordshire Primary Care Network, and I just want to start off by saying thank you, Jacob, for introducing AccuRx into my life. It's been an absolute game changer, and you're absolutely right that it's the nuance. So I'd been looking for years for a text messaging service to just let patients know the simple day-to-day stuff, like your scan's back, it's normal, your bloods are back, and it's normal. It doesn't mean to say I don't want to have another conversation, but just giving them a heads up. so that they can plan their lives. I mean, it's been, but it's been transformational for me. And Matthew, just to reassure you that by doing that, it enables me to free up more time, because I can do often those messages in between patients or for the DNAs. So if someone doesn't turn up, so I've got more time to then spend with the patients who do say, and one more thing, because I've got more time, because in my time, I can actually then control that to be able to message patients at any time, and then they can pick it up at convenience at the end of the day. So that's been huge. My question is, what opportunity do you see in secondary care? Because it's been transformational for us in general practice, and I think we're pretty lean already in terms of working out those efficiencies, although you experienced in some practices that communication was a problem. But just what do you think those opportunities are? Because my observation in secondary care is that it's pretty bad, really, sort of in terms of the use of technology, and therefore the opportunity must be even greater.
Yeah, so in terms of the opportunities, and this is like the biggest challenge we have, right? We're trying to make it easier to communicate. The opportunities, there are literally thousands of them. We don't come up with them, the frontline stuff. All the examples you just listed, like you came up with, not us. But we spoke through some of them there around taking pathways where we're bringing patients in for appointments that didn't need them, and now those we can resolve that remotely. I'll talk through one example. It's actually a personal one. So I'm a patient, a big teaching hospital, under two specialties, respiratory. I've got a condition called bronchiectasis. It's like pretty mild and well controlled. I have an appointment every 3 months that I don't need. So I have this like moral dilemma of, do I go to an appointment I don't need, or do I DNA? I genuinely don't know what the right answer is. Obviously I try and cancel. It's like almost impossible to. And then I'm under another team in gastro, where I do actually need to interact more. I send them an email. They send me, okay, we're going to send off this test. Okay, we're going to update your prescription. Very rarely have appointments. In the same hospital with the same IT. Two very, very different experiences. Both one much better as a patient, but also like vastly more efficient as the system for the system. And so those are the sorts of opportunities, I think, in terms of changing how outpatients is working across the system, is one of the biggest. The other huge one that we see is this communication between providers. So in GP practices now, it takes 2 clicks to message a patient. Click a button, type a message, hit send. We're trying to make it as easy to message a patient's district nurse. So when they're there tomorrow, they can also check these observations. Or trying to make it as easy to message cardiology so you can get some advice and guidance instead of having to refer. And I think we can't actually deliver integrated care until it is that seamless for people to communicate across the system, not just in the acutes, but across the whole system. So those are some of them. But the really exciting bit is like the biggest and best opportunities we don't know yet, because frontline staff are going to go and find them. That we find quite inspiring.
There is a question on the slide. How do you deal with potential adult or child safeguarding issues? How can you be sure that the person you're messaging is the right person?
Yeah, it's a very good question. What we generally find is that clinicians are quite aware of their patients and scenarios. They have flags on their system where there's safeguarding concerns. And so, again, we put the trust in them to know, okay, actually for this patient, this might be appropriate, this might not be appropriate. We're doing some work, for example, with the NHS app, so we can have a more authenticated channel and route things directly, make sure we've got really strong audit trails, things like that. But I'd say this is one of the areas where there have been concerns. We've sent north of 1 billion messages to patients. We do about a couple of million every day, and we're constantly monitoring, very proactively monitoring. Okay, what are the issues coming up? And these things are this particular one fortunately hasn't, because clinicians know their patients very well and plan around that.
Okay. Should we take, I think we've got time for maybe one more question from the audience. I'm being pointed at the back there. Is there a microphone up there?
Thank you. Thank you for the conversation. Hugely interesting, that marriage between technology and implementation, hugely important. Question, Jacob, I suppose from your perspective, I heard you say there that implementation is key. We're talking about a intervention in different settings. What lessons have you learned about how that implementation support has had to change over that time? And a question, Matthew, for you to reflect on, perhaps, how can the NHS help our industry partners with that implementation support?
I think what we've learned is exactly what Matthew was talking about. Is like it comes from relationships. It comes from there being some shared vision, then some shared ambition and urgency for change, and also from celebrating the wins together. So one of the things that starts to snowball is make some changes, you get some wins, then people get more ideas, put in place more changes. But I'd go further than implementation is key. I think implementation is everything here. What I spoke through is not, a lot of it isn't groundbreaking, because I don't think the solutions are groundbreaking, but change is just really bloody hard.
Matthew, do you want to finish?
Yeah, and actually this session is a great example of how I'd answer that, which is that for the Confed, partly because we really enjoy our commercial partnerships and partly because we're increasingly getting into the space of improvement. For me, it's about the quality of the conversation that we have, and it's really about coming back continuously to what is the theory of change here. Not just what is the product, and not just the impatience that you've got that people aren't using this product or prescribing this drug. Let's get under this and understand what the resistance to change is, and let's accept that resistance to change as being, if not legitimate in the sense that it might be misguided, it's still real. And we need to understand it, and then we need to work together to say, okay, if we both believe that this is something that's going to make the world a better place, what are the processes? We spend a lot of time in the NHS, everyone spends a lot of time in conversations that are not designed to reach any kind of solution or make any kind of progress. So how do we design the kind of processes, the kinds of engagements that really do empower people to want to leave the room and go, okay, I can take the next step now. So for us, it's about having a conversation that's absolutely focused on resistance to change and a theory of change and developing processes that lead to change.
Well, I think we need to wrap up now. So thank you very much, Matthew. Thank you, Jacob. And thank you, everyone, for your attention this morning.
Thank you.